At the Royal College of Anaesthetists, we've been thinking about how to make surgical care more efficient and effective by integrating the care patients receive before, during, and after surgery. Around 10 million patients undergo surgery in the NHS every year, and we believe there's huge potential to make this system work better, particularly for the group of 250,000 patients at high risk of complications, who account for more than 4 out of every 5 deaths after surgery. Here's an example. Meet Doug. He's just been diagnosed with bowel cancer, and his surgeon has told him he needs an operation to remove the tumour. Doug's GP has also been treating him for lung disease caused by his smoking and is aware of some problems with his kidney function, but this is not making Doug feel unwell. In the current system, Doug's anaesthetist may not receive this information until the actual day of his operation. Despite the lung and kidney issues, it's thought that surgery is Doug's best option. Like the majority of operations, it's a technical success and the tumour is removed. But a few days after surgery, Doug's weakened lung function deteriorates and he develops pneumonia, so Doug is admitted to a critical care unit for more intensive treatment. He ends up staying in hospital 5 days longer than originally planned, before he's fit enough to go home with his family. As well as the pneumonia, Doug's kidney function gets worse, but because he doesn't show any symptoms, it goes unchecked. And in the months which follow his operation, Doug gradually develops chronic kidney disease. So despite successful surgery for cancer, Doug is actually less healthy than before and eventually requires kidney dialysis treatment on the NHS. When we zoom out and look at this pathway and see Doug's repeat visits to hospital, we can see it's very complicated and uses lots of resources. Let's compare that to another pathway for Doug, where we take a simpler, more integrated approach. So how does it work? In this scenario, Doug is referred to a perioperative medicine team as soon as the surgery is planned, and one of the doctors on the team, in this case an anaesthetist, will oversee his care throughout the pathway. This gives his GP a service they can raise his other medical problems with, so the perioperative medicine team realise Doug has a high risk of complications and run some quick tests. This helps the team identify all his conditions up front. Using this information, the perioperative medicine team decide to help him stop smoking and put Doug on an exercise programme to improve his lung function before surgery. The team also alert a kidney physician to monitor Doug's kidneys before and after surgery. Now, after Doug goes in for his successful surgery, he is admitted to the critical care unit for a couple of days straight after the operation. So he gets extra care from the nurses and doctors, as well as physiotherapy. All of this helps him avoid pneumonia, and he gets to go home quicker. The perioperative physician, the kidney physician, and Doug's GP all stay in touch, monitoring Doug's condition and adjusting his medicine so he avoids a return to hospital and doesn't need dialysis. It's clear that this pathway is better for Doug and frees up hospital beds, meaning fewer operations are cancelled for other patients. Currently, over £16 billion is spent every year on surgery in the NHS, and we believe perioperative medicine will help NHS commissioners and providers achieve even more with this money. That might seem ambitious, but the good news is that all the skills and personnel are already available within the NHS. We simply propose organising them into perioperative medicine teams to assess and treat patients before surgery, to coordinate their care in hospital, and to review any unresolved problems after they go home. Each patient would remain under the care of the perioperative medicine team throughout their entire journey. This would give GPs and surgeons a point of contact, centred around the patient, providing better communication. Most patients are at low risk of complications and won't need a major change to their pathway of care. But for the growing number of high-risk patients, we can make small changes to vastly improve their treatment. This thinking is being put into practice already. 4 out of 5 NHS hospitals already have some form of anaesthetic assessment clinic. Exercise testing before surgery is available in 2 out of 5 NHS hospitals. And 92 hospitals are taking part in a major clinical trial to develop perioperative medicine for patients who need emergency abdominal surgery. It's time to work together to make perioperative medicine a reality, setting up the NHS to provide efficient, high-quality care for every patient who needs major surgery. Thanks for watching.